Hello, my name is Chengyuan Wu, and I'm a stereotactic and functional neurosurgeon at Thomas Jefferson University in Philadelphia, Pennsylvania. Over the past decade, I've been fortunate enough to be able to incorporate laser interstitial thermotherapy, or LITT, into my clinical practice. So it is really my honor to be able to share the insights and experience that we have with this technology as part of Stereotactic Academy. Specifically, I would like to talk about the applications of LITT in mesial temporal lobe epilepsy, which is the indication in which we have the most experience. So in this lecture, I will be discussing the role of laser interstitial thermotherapy and how it fits into the treatment paradigm for mesial temporal lobe epilepsy. Here is a list of my current disclosures. The only relevant disclosure is that I am a paid consultant for Medtronic, which is one of the companies that manufactures a laser ablation system. To get started, it is important to be clear about the indication for surgery in epilepsy. Surgery is indicated in the instance of drug-resistant epilepsy, which the International League Against Epilepsy has defined as a failure of adequate trials of at least 2 tolerated, appropriately chosen, and appropriately used anti-epileptic drug regimens to achieve freedom from seizures. This definition is largely founded on the work of Kwan and Brody. They have demonstrated that the chance of a patient achieving seizure freedom after trying 2 anti-epileptic medications is truly quite low. It is important to note that this continues to hold true even with the introduction of new anti-epileptic medications. In 2018, they again demonstrated that there is less than a 2% chance of achieving seizure freedom after failing at least 2 medications. Ultimately, approximately a third of patients with epilepsy fall into this category of being drug resistant. So it is critical that we consider surgical options for these patients. We know that we can achieve excellent outcomes for them because of decades of experience with open surgery for epilepsy. Since we are focusing on temporal lobe epilepsy, what you can see here is that approximately 70% of patients maintain seizure freedom 2 years after surgery. There's also robust long-term outcomes with more than 50% remaining seizure-free beyond 10 years. But despite this robust data on surgical outcomes, epilepsy surgery unfortunately remains significantly underutilized. A big part of that is the stigma of brain surgery. This is a study that was published in 2010, which sought to investigate patient beliefs about both epilepsy and brain surgery. If you look on the right-hand side, you will see that the majority of patients thought that death and memory loss were frequent outcomes from surgery. And a large portion of patients thought that paralysis, stroke, and personality change occurred commonly as well. But what is most concerning is the conclusion patients come to based on these perceptions. When asked if your epilepsy doctor told you that brain surgery was guaranteed to stop your seizures without causing brain damage, would you be willing to have surgery? Shockingly, approximately half of all patients said no. And keep in mind that this is with the guarantee of cure in the setting of no risk. So it is in light of this massive hurdle that we must consider alternatives that may be more palatable to patients with drug-resistant epilepsy. Laser interstitial thermotherapy, or LITT, can serve as a minimally invasive alternative to open surgery and may be considered by more patients as a viable surgical option. Currently, there are 2 laser ablation systems available for soft tissue ablation in the brain. They are capable of delivering laser energy at a wavelength of 980 nanometers or 1064 nanometers in a pulsed or continuous fashion. The probe itself measures between 1.65 and 3.3 millimeters in diameter, with an exposed aperture of 3 to 10 millimeters in length. This is the opening from which the laser can be emitted at the tip of the laser probe. Depending on the system, this aperture may be circumferential or diffusing, or have the capability to direct the laser energy towards a specific direction. The laser itself is placed in the operating room in a stereotactic manner and secured with an anchor bolt. Once in place, the patient is moved to an MRI scanner for the remainder of the procedure. In truth, the pairing of laser ablation with real-time MR thermometry is one of the most significant benefits of this technology, as it allows us to modify the ablation to maximize coverage of target tissue while minimizing involvement of nearby critical structures. During the ablation, the laser probe is simultaneously cooled with either saline or compressed CO2 to prevent charring of adjacent tissue and adherence of this tissue to the laser itself. As a whole, this system allows us to create ablation cavities that measure anywhere from 15 to 40 millimeters in maximal diameter. Certainly, smaller diameter lesions can be created by turning on the laser for a shorter amount of time or using a lower power. The shaping and customization of these ablation cavities is made possible with the use of MR thermometry for real-time imaging of temperature changes in tissue. This is an important distinction from radiofrequency ablation, in which the temperature set by the surgeon dictates the temperature of the probe itself, not of the surrounding tissue. It is for this reason that we have a better idea of exactly what we are ablating in real time with laser ablation. Specifically, MR thermometry is based on gradient echo imaging. Normally, we use images based on the magnitude of MR images, but for MR thermometry, we use the gradient echo phase image, which is particularly sensitive to changes in temperature. We can then quantify regional changes in heat by looking at the changes in the phase image that occur relative to a baseline image. The tissue temperature can then be estimated under the assumption that the baseline images represent a temperature consistent with body temperature. This constant comparison with a baseline image is important to remember with laser ablation because it emphasizes the importance of image alignment and the impact of patient movement during the ablation procedure. So ultimately, if there is patient movement, temperature estimates are no longer reliable under those circumstances, and a new baseline phase image must be acquired. In order for us to properly leverage these MRI thermometry images, we need to have an understanding of the relationship between temperature and the destruction of tissue. As you can see here, at temperatures below 43 degrees Celsius, thermal damage does not occur, regardless of exposure time. When tissue temperatures are between 44 and 59 degrees Celsius, there is time-dependent thermal damage. But at temperatures of 60 degrees Celsius or greater, there's instant cell death with instant denaturation of proteins and cellular components and tissue coagulation. These relationships of time and temperature as they relate to tissue damage can then be incorporated with MRI thermometry in order to provide damage estimates during the laser ablation procedure. In this video, on the left side, you will see a heat map of each of the temperatures, and on the right side, you will see the calculated damage estimate. As you can see, multiple ablations can be achieved by pulling back the laser fiber during the ablation procedure. What is also important to note here is how the cistern acts as a heat sink as it's filled with CSF and does not allow heat to pass towards the brainstem. In this manner, we are able to adequately cover the target structure, which in this case is the amygdalo-hippocampal complex. In addition to MR thermometry control and real-time visualization of the ablation zone, MRI-guided laser ablation has an additional benefit over radiofrequency ablation in that it possesses a much narrower transition zone between ablated tissue and tissue that is ultimately spared. As you can see here, that transition zone is on the order of 1 millimeter for laser ablation, whereas for radiofrequency ablation, it is much larger, on the order of 5 to 10 millimeters. As a result, laser ablation allows for greater precision of ablating target structures while avoiding critical structures that should be avoided. With this understanding of how laser ablation works, we can now turn our attention to the outcomes that we see with LITT for mesial temporal lobe epilepsy. Here you can see a summary of the early publications from single center experience with laser ablation for mesial temporal lobe epilepsy. What you'll notice is that there is certainly a wide range of rates of seizure freedom. These depend partly on the duration of follow-up. But when compiled and looking only at follow-up of at least 12 months, we see that in 187 patients, there is an average seizure freedom rate of 57%. But with any surgical procedure, we must carefully weigh risk with benefit. And this is especially true for minimally invasive procedures such as laser ablation. in which the benefit may not be as great as with open surgery, but this may be offset with lower morbidity and risk of the procedure. In the early experience with laser ablation for temporal lobe epilepsy, this was certainly true. What was seen was that although there are still declines in verbal memory with laser ablation compared to open lobectomy, there is a possibility of preservation of contextual verbal memory, and also naming in general was not as significantly impaired with laser ablation. So ultimately, it is important to consider the benefits of language preservation when considering LITT for mesial temporal lobe epilepsy. Coming back to seizure outcomes, one of the first questions we had was with regards to the role of the ablation size, both with regards to the overall ablation, as well as the degree of ablation of the target structures, namely the amygdala and hippocampus. But as you can see in these 4 series published between 2015 and 2018, there was no correlation between ablation volume and seizure outcome. And we also saw this in a subsequent analysis that we performed on 40 patients treated at our center. What we began to have a sense of was the importance of ablation location more so than ablation volume. So we began to focus on the analysis of this variable instead. With this in mind, we went on to perform a retrospective analysis of the early experience of laser interstitial thermal therapy for mesial temporal lobe epilepsy at 11 epilepsy centers in the United States. And we did this not only with the goal of capturing seizure outcomes, but also understanding factors of patient selection and ablation location and how they are relevant to overall clinical outcomes. Since that 2019 publication, we have continued to collect data on these patients, such that we have been able to expand the initial cohort of 234 patients to 268 patients. In addition, we've been able to capture longer-term outcomes for this patient cohort. So what you see here is a breakdown of the most recent analysis performed this year in 2022. As you can see, the majority of patients have mesial temporal sclerosis, or MTS. They also have concordant PET imaging as well as concordant EEG, and their seizures primarily manifest as focal impaired awareness seizures. If you look at these patients that have concordant information on multimodal data, in other words, the presence of mesial temporal sclerosis, no dual pathology, concordant EEG, concordant PET imaging, and concordant invasive monitoring if performed, we refer to these patients as having concordant MTS. And as you can see, this patient cohort represented only about 50% of the entire group. So as we look at the clinical outcome data, it is important to note the heterogeneous nature of this population and understand that this is real-world data that is not isolated to only the straightforward clinical scenarios in which LITT would be indicated. What we saw in this cohort was that at 6 months, 66% of patients were seizure-free and 56% were seizure-free at 1 year. And this was maintained to approximately 50% at 2 years follow-up, as well as at last follow-up, which was an average of 4 years later. If we consider rates of meaningful seizure reduction, or in other words, both angle 1 and angle 2 outcomes, we see that at 6 months, 76% of patients had meaningful seizure reduction, and this was maintained to 74% at 1 year, 75% at 2 years, and 66% at last follow-up. What you'll also see here is that a small percentage of patients underwent either a repeat LITT procedure or a follow-up anterior temporal lobectomy, which I'll discuss later on in this presentation. With regards to adverse events in this cohort, the most common occurrence was with regards to vision. Specifically, 4.3% of patients reported a visual field deficit, and extraocular motor dysfunction was seen in 2.5% of patients, although in half of those patients, those symptoms resolved over time. Otherwise, there was a 1% or less chance of symptomatic or persistent side effects from LITT for mesial temporal lobe epilepsy. Of note, given the retrospective nature of this analysis, The data is subject to some degree of reporting bias, as we were entirely dependent on what was maintained in the medical records for noting the presence or absence of any side effect. The most interesting finding of this analysis was really with regards to the ablation location seen in this patient cohort. What we were able to do was co-register non-linearly the patient images to a common atlas space. And by doing that, we were able to represent the ablation cavities for all patients in a single heat map. So what you will see here on the left-hand side is a positive predicted value map. And what that represents is a voxel by voxel based analysis in which the value of the heat map represents the likelihood of achieving seizure freedom in the event that that particular voxel was actually ablated. Just as important, on the right-hand side, we have a negative predictive value map. And what that represents is the likelihood of not achieving seizure freedom if a particular voxel was not ablated. So in both scenarios, the important areas of ablation are represented by voxels that have higher percentage values. So starting on the right-hand side with the negative predictive value map, you see that it is certainly important to ablate the amygdala, the hippocampal head, as well as the hippocampal body. What is interesting to note here is that this also gives us valuable information about the posterior extent of the ablation, because as you can see here, if we draw a line in the plane of the lateral mesencephalic sulcus, the heat map drops off drastically after that point. And so the likelihood of not achieving seizure freedom if you miss the areas posterior to that line are certainly lower. Looking on the left-hand side, back at the positive predictive value map, we can see that it is important to ablate medially here, as well as anteriorly in order to maximize chances of seizure freedom. And those structures involve really the parahippocampal gyrus, the entorhinal cortex, as well as the more mesial portions of the amygdala, extending even up towards the piriform cortex, as you can see here. If we distill this down to the appearance of a favorable ablation, we have the volume outlined in green. And again, to reiterate, that involves ablation of more mesial, anterior, and inferior structures, including the amygdala, the hippocampal head, parahippocampal gyrus, entorhinal cortex, perirhinal cortex, as well as the piriform cortex. And we also see that ablations extending beyond the lateral mesencephalic sulcus are less likely to be associated with seizure freedom. Meanwhile, if we stylize and show a suboptimal ablation, that is represented in the red volume. And that you can see is located more laterally, superiorly, and posteriorly. And if we look at these subcohorts of ablations centered around the more optimal ablation volumes versus those around the suboptimal ablation volumes, there are certainly differences in seizure outcome, where in this analysis, we are seeing seizure outcomes upwards of 70% or greater when looking at the subgroup of optimal ablations. So certainly that speaks to the importance of ablation location when we talk about laser interstitial thermotherapy for mesial temporal lobe epilepsy. I do want to take a moment to highlight the piriform cortex as part of the limbic circuit, as well as a critical mesial temporal lobe structure. The piriform cortex sits superior to the amygdala along its posterior aspect and consists of both a temporal limb inferiorly as well as a frontal limb superiorly. And this structure has been shown to be highly epileptogenic in animal models. Specifically, the piriform cortex is highly interconnected with both the entorhinal cortex as well as the perirhinal cortex, and also has connectivity to the amygdala as well as orbital frontal cortex. Specifically, it is the area tempestus within the posterior portion of the piriform cortex that has been shown to be highly epileptogenic in these animal models. We are now beginning to understand the importance of this region as a surgical target for mesial temporal lobe epilepsy. The importance of the piriform cortex in the surgical outcome from epilepsy surgery has been highlighted in prior work involving volumetric analysis of the piriform cortex. In a multicenter analysis of 138 patients who underwent anterior temporal lobectomy for mesial temporal lobe epilepsy, it was found that the piriform cortex in particular was important in predicting the chances of seizure freedom, with significantly more piriform cortex resected in the seizure-free group relative to the not seizure-free group. And of note, this is with regards to the temporal limb of the piriform cortex. More recently, a similar volumetric analysis has suggested the importance of piriform cortex ablation in seizure outcomes after mesiotemporal lobe epilepsy. Specifically, in their multivariable logistic regression, only the percent of piriform cortex ablation proved to be a significant predictor of seizure freedom both at 6 months and 1 year after laser ablation. So there is certainly a growing body of evidence in support of targeting the piriform cortex in the setting of mesiotemporal lobe epilepsy. Given this role of the piriform cortex in mesiotemporal lobe epilepsy, it is interesting to note this modeling study, which looked at the ability of a single laser trajectory versus 2 laser trajectories to cover the mesiotemporal lobe structures, including the piriform cortex, amygdala, perirhinal cortex, entorhinal cortex, hippocampus, and parahippocampal gyrus. And what this group identified was that the use of a second laser trajectory was able to better cover these structures in their entirety. In addition to ablation location, there are patient-related factors that are relevant to seizure outcomes after LITT. One of my collaborators, Brett Youngerman from Columbia University, has taken a closer look at the details of the timing of seizure recurrence as well as the factors associated with seizure recurrence after LITT for mTLE. And what we have seen is that if seizures do recur, they tend to happen early within the first 10 months. In addition, the seizures that do recur tend to be of the same semiology, with approximately 70% of patients having the same seizure semiology at the time of recurrence. When looking at specific predictors of seizure recurrence, we can see the importance of having high confidence of localization of seizure onset to the mesiotemporal lobe. The presence of discordant PET imaging increases the likelihood of early seizure recurrence by more than 4-fold. Of all the other variables investigated, the presence of focal to bilateral tonic-clonic seizures, as well as younger patient age, also proved to be significant predictors of seizure recurrence. What is equally or even more interesting are the variables that were not predictors of seizure recurrence, specifically the presence of MTS on MRI, dual pathology, discordant EEG localization, and the use of invasive monitoring. None of these variables were associated with earlier seizure recurrence. This data certainly brings up an interesting question of how stringent we really need to be when selecting a patient for LITT. As I alluded to earlier, there are certainly scenarios where patients underwent subsequent surgery after failure of LITT. One option is certainly proceeding with a standard anterior temporal lobectomy. In this scenario, the surgeon must be familiar with slight but significant differences in the surgical procedure if performing it after a laser ablation. Of note, there is significant distortion of the mesial structures as one would expect, and this can certainly affect the identification of the temporal horn, as the surgeon may not notice a significant rush of CSF that is typically identified when localizing the temporal horn during a temporal lobectomy. In addition, there is significant scarring of the pia on the mesial surface, which can make resection more challenging and may necessitate the use of ultrasonic aspiration as opposed to suction and bipolar cautery. In this specific cohort, whether a subsequent anterior temporal lobectomy or repeat laser ablation was performed, the rates of seizure freedom after this follow-up procedure were comparable to if it were performed as a de novo procedure, with approximately 65% seizure freedom at 1 year and at last follow-up with anterior temporal lobectomy, and 50% seizure freedom following laser ablation. Pulling all of this together, we can look at the American Society for Stereotactic and Functional Neurosurgery position statement on on laser interstitial thermal therapy for the treatment of drug-resistant epilepsy. Ultimately, although LITT has failed to match seizure freedom rates associated with open resection for indications like mesial temporal lobe epilepsy, this shortcoming must be carefully considered and balanced with potential risks including neurocognitive side effects and procedural morbidity. In addition, it's important to keep in mind that much of the literature to date is based on the early experience with LITT. And over the past several years, we have certainly learned a lot about the nuances of ablation location and trajectory planning to achieve the optimal ablation. So there is certainly potential for improved seizure outcomes based on this new knowledge. Finally, it is important to note that there remain salvage procedures for instances of poor outcome with LITT for mesial temporal lobe epilepsy. Specifically, standard anterior temporal lobectomy and repeat LITT can be performed with clinical outcomes comparable to patients who had not previously undergone laser ablation. Laser interstitial thermal therapy should certainly serve as a minimally invasive option in scenarios where the seizure onset zone is clearly identified. And we have seen that this option clearly provides greater benefit in patients with drug-resistant epilepsy when compared to medical management alone. And with that, I would like to thank you very much for your time and your attention.